Thank you very much, Jan and Jan. Good morning, everyone.
Yeah, I think so.
My conflicts of interest are on this slide. So first, I would like to go back to some definitions about venous return determinants. Venous return is, according to the Guyton's model, the ratio of the venous return pressure gradient, the mean seismic pressure, the upstream pressure, minus the right atrial pressure, the downstream pressure for venous return, divided by the resistance to venous return. And we like to refer to this Guyton's model with venous return on the y-axis and right atrial pressure on the x-axis. And when right atrial pressure increases, so the downstream pressure increases, this should be associated with a decrease in venous return. And if we extrapolate this line to zero flow, zero venous return, Guyton also proposed to estimate the mean seismic pressure, the upstream pressure for venous return, which is the pressure of the circulation at zero flow. And it could be considered a marker of the effective blood volume. So, if I summarize, according to the Guyton's model, the systemic venous return is proportional to the pressure gradient for venous return and inversely related to the resistance to venous return. The pressure gradient for venous return is the difference between the mean seismic pressure and the right atrial pressure. And the mean seismic pressure, which is a virtual pressure, considered to lie at the level of the venules, is positively related to stress blood volume and negatively related to vascular compliance. And the stress blood volume, which represents 30–40% of the total blood volume, is hemodynamically active and participates in venous return through its impact on the mean seismic pressure. And the unstressed blood volume, which represents 60–70% of the total blood volume, is hemodynamically inactive and serves as a blood reservoir that can be mobilized and be converted to stressed blood volume under some critical conditions. Having said that, we also should remember that venous return and cardiac output are equal at steady states. So we also have to consider the Frank-Starling mechanism. And for example, for normal cardiac function, we have this kind of Frank-Starling curve. And of course, because they are equal at steady state, there is an optimal point for right atrial pressure and for cardiac output, which is this equilibrium point, which is the crossing point between the two curves, Guyton, I would say Guyton curve and Frank-Starling curve. If there is an increased cardiac adrenergic activity, there is a shift of the Frank-Starling curve without change in the Guyton curve, and therefore there is a movement of the equilibrium point to the left, meaning that cardiac output is increased and the right atrial pressure is decreased. And the opposite, if we have a decreased cardiac contractility, there is a downward shift of the Frank-Starling curve, and therefore cardiac output will go down and CVP or right atrial pressure go up. So, what are the main implications for shock resuscitation? Just to summarize the effect of mechanical ventilation, because Professor Pinsky already talked about this. We know that at each mechanical insufficiency, we should have an increase in the alveolar pressure, which should increase the intrathoracic pressure, which should increase the right atrial pressure, which is the downstream pressure for venous return. At the same time, we have a descent of the diaphragm, and therefore this should increase the abdominal pressure, but less than the increase in intrathoracic pressure. And this should improve, or this should increase the mean systemic pressure. And therefore, this can counteract the effect of mechanical insufflation on the right atrial pressure. If I summarize this on this graph, I start from these values. There is an increase in the intrathoracic pressure during mechanical insufflation, and this will decrease cardiac output if we consider that the right atrial pressure increases, like this. Nevertheless, there is an increase in the abdominal pressure, which will shift the venous return curve to the right, and therefore, finally, we should have a decrease in cardiac output, but less marked due to the increase in the abdominal pressure. Let's go to the effects of fluid infusion, which is a usual treatment of patients with shock. Normally, fluid infusion should not affect the Starling curve, as it is expected not to change the cardiac systolic function. This is physiology. But fluid infusion should increase the mean systemic pressure. And in this paper with Laurent Guérin and Xavier Mollet in our unit some years ago, we tried to estimate the mean systemic pressure before and after fluid infusion. And for this, we performed some maneuvers, some hold maneuvers in patients who receive mechanical ventilation. We perform an inspiratory hold maneuver, which will be associated with an increase in CVP, but a decrease in stroke volume and cardiac output. So if we do this many times before and after PEEP application, for example, we can have different points, different couple of points, different couple of values of cardiac output and CVP at the same time, measured at the same time. And we also can do this during an expiration hold, which should decrease CVP and increase stroke volume and cardiac output at the same time. So if we do this, if we repeat this with low PEEP level and high PEEP level before and fluid infusion, we should have some different couple of values, and we could reconstruct a venous return curve, and we could extrapolate the regression line to zero flow to estimate the mean systemic pressure. This is what we did here, before and after, and we found that in every patient, there was a shift of the venous return curve to the right, which is consistent with physiology, of course, and an increase in the mean systemic pressure. Interestingly, we found this regardless of the presence of pleural responsiveness, and we found exactly the same result in patients who will increase cardiac output after fluid infusion and in patients who will not. There is no difference. Therefore, this increase in the mean systemic pressure after fluid infusion occurs in all cases, in pleural responsive and non-responsive patients. But fluid infusion should increase the venous return pressure gradient only in case of pleural responsiveness. Why? It is very simple to understand. So this is my starting value, CVP, mean systemic pressure. I give fluid. There is a shift of the venous return curve to the right, an increase in mean systemic pressure, and therefore I should have an increase in cardiac output with a limited increase in CVP because the ventricles are working on the steep part of the Frank-Starling curve. So the increase in CVP is less than the increase in mean systemic pressure, by definition, I would say. And this is exactly what we found in this study. We found that in fluid-responsive patients, there was an increase in the venous return pressure gradient, the difference between the mean systemic pressure and CVP. But in patients who are not fluid responsive, so patients with fluid unresponsiveness, the ventricles are working on the flat part of the Frank-Starling curve. And therefore, if we start from these values, we give fluids, there is a shift again of the venous return curve to the right, an increase in mean pressure, but because the ventricles are working on the flat part, by definition, I would say, there is a marked increase in CVP, and therefore, more or less the same as the increase in mean systemic pressure. There is no increase in the mean systemic pressure minus CVP difference. And of course, there is no increase in cardiac output, but also there is a high increase in CVP, and sometimes it is harmful for the kidney function or the liver function. And this is what we confirm here. We confirm that in non-responsive patients, we have no change in the venous return pressure gradient. So, fluid infusion should increase cardiac output only in case of pleural responsiveness. This is consistent with physiology. So, if we summarize here these two situations, pleural responsiveness and pleural unresponsiveness, we should have an increase in the venous return pressure gradient only in case of pleural responsiveness. This is summarized in this recent paper we did with Romain Persichini, Xavier Monet, and others. What about the effects of norepinephrine now, which is also an usual treatment for patients with vasodilatory shock? It is interesting because the effects are a little bit more complex. In these two papers we did with Olfa Mzawi and Xavier Monet in the past, we looked at the effects of early administration of norepinephrine on preload parameters and preload dependency. And the messages of these two papers were that norepinephrine is able to increase cardiac preload, to increase cardiac output in preload-dependent patients, and to reduce the degree of preload dependency. And this is exactly as fluid infusion does, in fact. So the effects are very similar. And what could be the mechanism? How does norepinephrine impact the venous circulation? Probably by blood redistribution from unstressed to stressed volume. And if we reconstruct the venous return curve according to the guidance model, and this is what we did with Romain Persichini and Xavier Monet in the past, we tried to use the hand expiratory hold and hand inspiratory hold maneuvers to obtain a couple of values of CVP and cardiac output at the same time. We could have a mean systemic pressure with norepinephrine and without norepinephrine, and if you can observe in this patient, the value of mean systemic pressure was higher with norepinephrine compared to before norepinephrine. But also, the slope of the curve was different, and you know that the slope is inversely related to the resistance to venous return, so it is totally consistent with pharmacology and physiology. Norepinephrine increases both the mean systemic pressure and the resistance to venous return. This is what we confirm in a series of patients with septic shock, an increase in the resistance to venous return, which is consistent with pharmacology. Of course, an increase in the arterial resistance, which was the expected effect to obtain a higher MAP. But we also observe an increase in cardiac index with norepinephrine, and also an increase in the mean systemic pressure, a marked increase in the mean systemic pressure. So, in spite of the increase in the venous resistance, venous return increases with norepinephrine through an increase in the mean systemic pressure related to blood redistribution from unstressed to stressed volume. So, norepinephrine should increase the mean systemic pressure, potentially the venous return, exactly as fluid infusion does, but in addition, norepinephrine should increase the cardiac contractility through the beta-1 effect, and this could improve cardiac output through the Frank-Starling mechanism. And this is what we confirm in this study with Olfa Mzawi and others, we gave norepinephrine very early in the course of septic shock, and we measured echocardiographic variables, left ventricular ejection fraction, velocity time integral, and on other indices, we observed that norepinephrine was able to increase LVF, to increase velocity time integral, and we also observed these effects in spite of an increase in afterload of the left ventricle, because the systolic arterial pressure, as said by Olfa and Mzaoui, increased with norepinephrine. So this suggests an effect on cardiac contractility, intrinsic cardiac contractility. And interestingly, we found exactly the same results in those patients with low left ventricular ejection fraction at baseline, lower than 45%. Also, these patients improved their left ventricular ejection fraction when norepinephrine was given early again. The mechanisms, the potential mechanisms can be an effect on myocardial beta-1 receptors not yet downregulated at the early phase, or an increase in the coronary perfusion pressure through an increase in the diastolic arterial pressure, as said by Olfa and Mzaoui before. So if I summarize on this cartoon, there is an increase in the stress blood volume and the mean systemic pressure with norepinephrine, so a shift of the venous return curve to the right. But due to the increase in the resistance to venous return, the slope is a little bit different. And at the same time, we have an increase in cardiac contractility, so also a shift of the Frank-Starling curve, an upright shift of the Frank-Starling curve. And therefore, cardiac output finally increased with norepinephrine, and the right atrial pressure does not increase so much. So if I summarize, an increase in cardiac contractility, an increase in stress blood volume and mean systemic pressure, an increase in resistance to venous return, but a final effect, a final increase in cardiac output and a minor increase in right atrial pressure and CVP. So the title of my presentation was, does it have bedside application? I tried to answer, but should we measure mean systemic pressure in clinical practice? Of course, I already talked about this technique, but it is very cumbersome. It is not practically applicable in our patients, and it could be reserved for research only, not for the clinical practice. And for the clinical practice, maybe we can use this other technique, the brachial arterial occlusion technique, using brachial cuff and to inflate the cuff in order to occlude the circulation and downstream circulation, of course. And if you have an occlusion of the downstream circulation, you should have finally an equilibrium with the venous pressure and the arterial pressure, and this could be an estimation of the mean systemic pressure for this territory, which normally reflects the mean systemic pressure in general. Okay, this is possible. Another catheter is required, of course. You don't need to measure the venous pressure, finally, because the decline of the arterial pressure is enough, but we need more validation before clinical application. Another possibility is to use this app, this iGuidon app. You can download this app for free on the internet, and this app is able to provide you the value of the mean systemic pressure, and you just enter the value of CVP, MAP, cardiac output, the age of the patient, the height of the patient, the weight of the patient, and you can have the values of the mean systemic pressure and the resistance and the venous return pressure gradient. But of course, we need cardiac output to obtain the value of the mean systemic pressure, which is calculated using an unknown formula. We need cardiac output measurements. So my conclusion is that, and I think it is not necessary to measure or even estimate the mean spirit pressure. What is important is that every ICU doctor should know the simple physiological and pharmacological concepts about venous return to better understand what they do when they give a treatment to their patient. Thank you very much for your attention.
Thank you very much, Jean-Louis. I get that it's basically a concept that should be in your, let's say, brain when you treat patients. Now, you alluded a lot to mean systemic filling pressure. What about resistance to venous return? How should that, let's say, be in your clinical evaluation at baseline before you do something?
No, it's difficult to evaluate, to be honest, of course. We think that the resistance to venous return can increase more or less, not proportionally, of course, but associated with increase in arterial resistance, because we think that the mechanisms could be more or less the alpha-1 effect. And therefore, if you look at the arterial resistance, maybe you have an idea of what happens with the venous resistance. But in practice, it is not available. And what I think is important is to know the concepts, to know the pharmacological effects of the drugs we give, including fluids, and also to know physiology and to try to think, to play with this in your mind. But to be honest, to try to determine at the bedside the determinants of venous return, I think today is not necessary because we have no accurate measures of venous return determinants.
Okay, thank you very much, Jean-Louis. To finish up this session, we had 4 great presentations. Michael Pinsky, Alpha Hamzoui, Vanina Edu from Argentina, and Jean-Louis. And I thank you all for your presence and your questions, and wish you a great lunch. And I thank my co-chair, Jan, for sharing the session with me.
Okay, thank you, Jan, and have a great day, all of you.